All right, so this is going to be the first of 3 lectures that cover the mediastinum, which is the central region in the thorax. In this lecture, we'll talk about the superior and anterior mediastinum. This next lecture, we'll talk about the middle mediastinum, and then the third lecture, we'll talk about the posterior mediastinum. So first, let's give you an overview of what the mediastinum is. So the mediastinum is this central region in the thorax, like I said. So here's an anterior view. Here's the axial view. It's this region in here, and what it is it's between the lungs and it separates the 2 pleural cavities. So you can see how I've drawn that in here. It extends from the sternum, which is right here, back to the vertebral column. So it spans this whole anterior-posterior diameter of the thorax in this region. And then it's bound laterally by the pericardium and the mediastinal pleura. So the pericardium would be that fibrous sac that encloses the heart, and then it's also the mediastinal pleura, which is in here, around the lungs, as we've talked about. It contains the heart, as you can see here, great vessels here, and it serves as a corridor through which structures from the head and neck region connect with lower regions of the body and vice versa. And a good example of that is the esophagus. So the esophagus starts in the neck, goes down through the thorax, through the mediastinum, and you can see that in here, it goes through the mediastinum, and then it goes to the diaphragm and into the abdomen to join the stomach. And that's one such example. There's vessels and other structures that go through as well. So the divisions. So, as I was talking about in the intro slide, there's the superior, inferior division, and there's the anterior, middle, and posterior mediastinum. So first, the divisions. There's superior division and inferior division. So the superior division begins at the manubrium here, and then it's this portion here, all the way back to the the posterior aspect of the thorax. And then the inferior division is everything below it all the way down to the diaphragm. And the inferior division actually has 3 subdivisions, and that's where I was talking about the anterior, middle, and posterior mediastinum. So the anterior is in front. The anterior is very small. It's in front of the heart, and that's where it's, the main structure there is the thymus, as we'll talk about. And then the middle mediastinum is the part that contains the heart here, and roots of the great vessels. That's the middle mediastinum. And the posterior mediastinum is everything all the way to the back of the thoracic cage. So this is our anterior, middle, and then posterior here. So that's our division. This is our superior, all this region up here. So the sternal angle, one of the most important bony landmarks in the thorax, it's the junction between the manubrium here and then this sternal body here. So this would be the level of the sternal angle here, and you can actually palpate this as long as the skin is not too thick over this in an individual, or they don't have too much fat here. You can actually palpate. You can palpate it on yourself. The sternal angle. It's this bony ridge where these 2 bones meet, and it's the boundary between the superior and inferior mediastinum. So above the sternal angle is the superior mediastinum. Below it is the inferior mediastinum. This is where the aortic arch starts and ends. So you can see the aortic arch here. So this would be about the level of the sternal angle. Here the arch begins. The root is below the sternal angle, but the arch begins here, and then it becomes the the descending back here. It's also where the trachea bifurcates. You can see that's kind of down in this region here, where it splits off into the 2 main bronchi. The azygous vein, which is a vein that helps drain from the abdomen and get blood around in case there's a blockage in the IVC, get blood up to the SVC. We'll talk about that in the vessels lecture, but it travels along the anterior surface of the vertebrae in the posterior mediastinum and travels up this way. At the level of the sternal angle is where that vein is coming around and draining into the SVC, which would be here. It's also where the thoracic duct passes from the right to the left behind the esophagus. So it's traveling on the right side, and then it passes to the left because it actually ends up emptying into the left side. It passes to the left side. So, again, this is your right, this is your left. It's going up this side, and then it crosses over at the sternal angle to go behind the esophagus and then eventually drain into the systemic veins. We'll talk more about that again in the vessels lecture. Now, the other landmark we have marked here is the first intercostal space, which is here. And what happens here is you have the right and left brachiocephalic veins, which come in like this and this, to join to form the SVC. So that's what's important about that area. All right, so now we'll talk about the superior mediastinum. So the borders, we'll talk about this as an axial cut here. We have the manubrium of the sternum here. That's the anterior. The thoracic T1 through T4 vertebrae posteriorly here. That's our posterior border. The parietal pleura is our lateral border, so in here and in here. And it's continuous superiorly with the neck. There's no, major structure blocking it off. It's just continuous with the neck. And then at the level of the sternal angle, it's continuous with the anterior, middle, and posterior mediastinum inferiorly. So it's continuous with the inferior division and all these three subdivisions. All right, so the contents for all these divisions of the mediastinum, we're going to break it down by arteries, veins, nerves, other important structures. So here we'll talk about the aortic arch. Let's draw in our sternal angle. So everything above this is superior mediastinum. So notice the aortic root is considered the middle mediastinum, but above that, superior mediastinum is the arch of the aorta, and then the descending aorta actually travels in the posterior mediastinum. It's behind the heart, as you can see here, and then here it comes out this down here. And its proximal branches are also considered part of the superior mediastinum, the branches off the aortic root, and we'll talk about that in a few slides when we talk more about the aortic arch in detail. Also, to note here is you have the left and right brachiocephalic veins before they join, down here in the medial mediastinum to form the SVC. It also has a portion of the azygous vein right before it drains into the SVC, and you can see that right here, where the azygous vein is coming down and right before it's going to drain here in the SVC. So important lymph structure involved is the thoracic duct that's traveling through. This is something that travels through multiple parts of the mediastinum. You can see it forms down here in the abdomen. It travels up the anterior surface of the vertebrae here, up through the posterior mediastinum, and then up into the superior mediastinum here, and then it drains into the junction of, this is actually wrong, you should mark this in your book, this is the left subclavian vein, and then the left internal jugular vein to form the left brachiocephalic vein. So I apologize about that, but it's an error. So it comes up in here, joins at this junction of the left subclavian, left internal jugular, just before it forms the left brachiocephalic vein. So this area as well would be called superior mediastinum. Now the nerves involved, the major one to be aware of is the vagus nerve. So here's the right vagus nerve, here's the left vagus nerve. Here they are traveling down next to these vessels coming off the aortic arch, traveling around the aortic arch here. Then you have the recurrent laryngeal nerve, which is important to know here. So you have the recurrent laryngeal, which you can see in this region as well here, and then it's traveling more posterior here behind these structures in the superior mediastinum as well. These are branches that come off of the vagus nerve. Then you also have the phrenic nerve here, which is the nerve that comes down from the neck and inserts onto the diaphragm and drives respiration by innervating the diaphragm. Here's the left phrenic coming down this way. You can get a good view of it here coming down. This travels through the superior mediastinum as well. You have some cardiac nerves, which are in the plexus. These are ANS, and then you have the sympathetic trunk, which you can't see too well because it's on just adjacent to the vertebral column on either side. So that would be more posterior to all these structures. Because if you remember, you have your vertebral column like this, and then you have your sympathetic trunk traveling on either side, and so this would be in the just posterior to these structures. Other structures is the trachea here, so you can see that nicely here. The left and right primary bronchi, which would be behind here, branching off this way as it bifurcates. And then you have the esophagus, which travels posterior to the trachea. So the trachea, it travels in the superior mediastinum anterior to the esophagus. So here's the esophagus here. The trachea is actually bifurcated in this diagram here. So if we show you, the heart here, like this is the heart. This would be the sternum here. And then you have, the trachea, which is traveling in here. And then you have the esophagus, which travels posterior to the trachea. And then you have the vertebral body like this. And then you have the ribs that, come out like this. So that's just to give you an idea of the spatial anatomy. The trachea bifurcates, which is the carina, which we talked about in the respiratory tree, which is the that ridge at the bifurcation at the level of T4, T5. So since it's already bifurcated here, we're probably just below the T4, T5 level. All right, so let's talk in depth about the aortic arch, very important structure. So its components, it has three subdivisions: the ascending aorta, so as you can see here, the aortic arch here, and then the descending aorta. So the portion that's in the superior mediastinum is the arch here. The aortic, the ascending aorta or aortic root. Aortic root is found in the middle mediastinum, arches around and then dives down posteriorly and inferiorly, and that's the descending aorta, which travels in the posterior mediastinum. So the aortic wall tissue actually receives a blood supply. It has its own network of small blood vessels that supply it. So you have what's called the vasa vasorum, and these are small blood vessels that, because the aorta is such a large and important structure that it needs its own blood supply to keep the wall healthy. Because you'll see what happens in a second here when we talk about aneurysms and dissection. What happens when the wall of the aorta is not kept healthy. And then another thing to note is they supply other large arteries and veins. So the SVC and the IVC also have vasa vasorum vessels as well. So within the superior mediastinum, the aortic arch, it gives off three main branches. So you have the left subclavian here, you have the left common carotid here. The left subclavian goes on to form, as we talked about in chapter 2, it goes on to form the axillary artery and then eventually the brachial artery and supply, the upper extremity. And then you have the left common carotid, which goes up into the neck and ends up becoming one of the major supplies in the brain. And then on the right here, you have the brachiocephalic artery, which is this portion right here, this short, artery that branches in, and then it bifurcates into the right common carotid, which goes up, just like the left, up into the neck, supplies the brain eventually. And then you have the right subclavian, which goes on to become the right axillary artery, and then the right brachial artery to supply the upper extremity. So an aortic aneurysm, it's a pathological dilation of the aorta. So it would be, if this wall were to become weakened and come out like this, and an aneurysm can happen here, it can happen here. It could happen even if you go all the way down here in the abdomen. It could weaken and kind of, it's almost like it's ballooning out. The wall becomes weaker. You can have a really large aneurysm that goes like this and spans, the root and the arch, or even longer. And so again, like we're saying here, it can occur at any point along the aorta, but it's actually most commonly seen in the abdomen. You may have heard the expression AAA, abdominal aortic aneurysm. And we'll talk more about that in chapter 4 in the abdomen lecture. So that's the most common site for aneurysm. And the major risk factors, these are actually very common board questions asking for what's the common risk factor. The most common for aneurysms is hypertension. Definitely want to make note of that. Some other ones are smoking, diabetes, hyperlipidemia. These aren't too surprising. These are, all these damaged blood vessels, all of these lead to, heart disease and other problems. So hypertension is the main one you want to remember, because if you remember, the aorta is a vessel, and so if you have hypertension, if you have increased pressure, you have increased stress on the walls of the aorta. And the aneurysms, it's all about weakening of the walls. So the more you increase the pressure in here, the more you increase pressure on the walls, and then that can lead to weakening and then ballooning out. So you can also have, these are good things to be aware of for your boards. Is genetic causes. So the Marfan syndrome, you have an elastin mutation. These people aren't able to produce elastin as much. These are the people, they're commonly very tall, way over 6 feet tall, very lanky looking, long fingers, long extremities. And the big thing here is, the aorta, as far as the aorta goes, there's a lot of elastic tissue in the aorta, because as the heart pumps in, pumps blood into the aorta, it's able to expand like this to accommodate more blood. And actually what happens is after the heart has pumped the blood in, while the heart's resting, is the aorta actually recoils. It's like stretching out a flexible, like a balloon or anything else. It's really flexible, elastic, and then it comes back to its original form. And by coming back this, it actually shoots another jet of blood. So the aorta helps do a kind of a second shoot of blood while the heart's resting in between beats. Okay. So if you lose that elastic tissue, you lose that ability to, be distensible during cardiac function and, pumping of the heart. So by losing that tissue, you lose, another structural support of the aorta, which makes them susceptible to aneurysms. Another is Ehlers-Danlos syndrome, which is a collagen synthesis defect. So collagen is also a main, connective tissue component, gives a lot of strength to the aortic wall. If you don't have, if you're not synthesizing collagen properly, the wall is going to be weaker, and it's going to put them at risk for aneurysms. Another important thing, so those vasa vasorum, so those vessels that come in, and they supply the wall of the aorta, that's their job. If you have disease processes of these, that can cause ischemia. It's just like, So if you have, plaque buildup in here, so you have atherosclerosis from, smoking and hyperlipidemia and other processes like that. If the blood flow can't get in, you're going to have ischemia of the wall of the aorta, and that can lead to aneurysm, because ischemia leads to, weakening of the tissue, and if you lead to weakening of the tissue, weakening of the wall, it's going to balloon out, and that's going to lead to an aneurysm. So again, examples of that: atherosclerosis. Good infectious disease is tertiary syphilis. So untreated syphilis can lead to damage of the vas vasorum specifically, and so by damaging the vas vasorum, you damage the blood supply to the aortic wall. So that's people with tertiary syphilis are at risk for developing aortic aneurysms. So aortic aneurysms, the classification, if you talk to, a cardiac surgeon, it can get very complex. As far as for what you want to know for your boards and, clinical rotations and just in general is you want to really just know type A versus type B. It can be much more complicated than this, but this is a good starting point. If you want to know more about it, you can Google it. There's the Stanford classification. There's the DaVinci classification. Go into much more detail. But type A, type B, this is what we'll cover here, and we'll leave it at that. So type A, it occurs very easy. Just remember A for ascending. Type A occurs in the ascending aorta, and it requires immediate surgery. And this makes sense. This is just distal here to the heart. Because the heart's here, and it's this would be a major, if you have the main vessel that's coming right off the heart with an aneurysm. This is also where the pressure is going to be the highest, because remember, blood moves from high pressure to low pressure. So this is where pressure is going to be the highest, because what you don't want to do is have these end up rupturing, because those are what you hear about with an aneurysm kills somebody instantly is if they rupture. And so since the pressure is the highest here, it's at risk for rupture, so it requires immediate surgery. These are the people you hear about. They come to the ER in the middle of the night with an aneurysm. They go to the OR right away. Type B aneurysms, however, they occur in the descending thoracic or abdominal regions of the aorta. So this portion down here and all the way down into the abdomen. And if these patients are stable, they can actually be managed medically by controlling the risk factors such as blood pressure, their lipids, so their cholesterol, along with scheduling imaging of the aneurysm. So these people need to be followed. They need to get a CT scan periodically to measure and measure the diameter on the CT scan, and you need to make sure that that diameter of the aneurysm is staying consistent. If it ends up growing, then you need to talk to either a cardiac surgeon or a vascular surgeon, depending on where it is, and if it needs to undergo surgical repair. So aortic dissection, this is the feared. This is much more serious than an aneurysm. So this occurs when blood pierces through the tunica intima of the aorta and enters into the medial layer. So if you remember, if you have those three layers of the vessel, so you have if this is your lumen right here, we'll mark that with L. This is your tunica intima. Okay, and then you have your muscular layer, which also has that elastic tissue. So here's your muscular layer, so tunica media. Okay, and then you have your adventitia out here, which is another connective tissue layer on the outer layer. So what happens is blood pierces through, so you have a tear in this intima, and then the blood pierces through and enters into this media layer, and that's what creates a false lumen. And this is a axial CT scan showing a great view of it here. This would be a dissection in the ascending aorta here. And what you can see here is you have this. This is the true lumen here. So the true lumen is the original lumen. So it's this lumen here in the original vessel. Then the false lumen is this lumen here. And this is an important thing to note, because there's a very good chance you could see an image like this on either your class exam or a board exam for sure. And you may be asking, now, why is the false lumen bigger than the true lumen? Now, what you need to remember here is that there's a tear in the intima here, and then blood is leaking into the tunica media. We'll clean this up here so we can show you. Is if we show this here, this would be a view of it here. This is your true lumen, your false lumen, same thing here, false lumen, FL, TL, true lumen. Okay, so you have a tear here, and the blood is leaking in here. This part of the wall is not very strong, because you've lost that integrity of the wall, and so you have blood that's constantly leaking in here and expanding the wall out, and you've lost the strength of the wall, and so that's what's enabling it to expand so dramatically like this. Versus if you look at, this is, if this is a cross section here of the aorta, you have your lumen here, you have your intima here, and then you have your very thick muscular layer. This contains the lumen, and so that's what keeps it, maintains its integrity. But the problem is, if you have the tear like you have in the dissection, it allows blood to just leak all in here. It leaks all in here, and that, balloons it out in all directions like this. Okay, so it's going to balloon it all. It's going to completely balloon out like this in all directions, and you have blood and remember that you have a lot of pressure in this true lumen because it's just off the heart, and so by pushing, you're gonna have a lot of blood pushing in from this area of very high pressure into this area of very low pressure. So you're pushing a lot of blood in here and expanding it. So that's what creates that false lumen. So we'll finish this out with a common question is, what's the difference between a dissection and an aneurysm? Okay, and we'll go over that. So an aneurysm is a ballooning out. It's a weakening of the wall. Okay, so if we have our lumen like this, and then we have our, our muscular layer like this that goes around like this. So we'll draw an aneurysm first. Okay, so an aneurysm is like this. Is what it's done is it's ballooning out because in this direction around, because what's happened here is the key is that the intima is intact. Okay, in an aneurysm, intact. Okay, and so this is, AA and aortic aneurysm, and we'll do dissection over here in a second. So the intima is intact in an aneurysm. That's the major difference. So, even though this wall is very weak, there's no blood accumulating in the immediate layer. There's no tear. There's no blood leaking in. There's no accumulation. The reason why it's ballooning out is because for some reason either you have Marfan syndrome and you don't have that elastic tissue, you have your vasa vasorum is full of atherosclerosis, and you have ischemia of the wall of the aorta. Something is causing the wall of the aorta to become very weak and expand out like this, like we've shown in this dotted line. Versus in an aneurysm, what you have here is the lumen has torn and the blood is leaking into this medial layer and expanding it out this way and this way and this way. And, again, you have this high pressure of blood here in the true lumen, and it's pushing blood into this false lumen and further expanding it. And that's the difference between an aneurysm and a dissection. The reason why a dissection is you have active bleeding here that's continuing, and you have blood that continues to accumulate. And the problem is if this isn't repaired urgently, it can rupture the entire wall of the aorta at a certain point and then bleed out, and this is what kills somebody. So a dissection is something that needs to be treated right away. You can't watch it like a type B aortic aneurysm. So now we'll talk about the anterior mediastinum. There's honestly not much to talk about. We'll hit on some key structures and some important clinical pearls, and then we'll finish this out. We'll get you out of here. So borders and content. The borders, it's the mediastinal pleural laterally. So that would be out this way, the pleura on the lungs. Body of the sternum anteriorly, which would sit just anterior to this thymus here. Pericardium posteriorly, which would be part of the heart, as you can see here, sitting here posteriorly. And then the diaphragm inferiorly, because this is going to go all the way down. We're in the inferior division here, so it's going to go all the way down to the diaphragm. It's continuous with the superior mediastinum superiorly, which would be, up in this region here. The only major structure is the thymus, which we show here, and it's usually only found in children. So in your cadavers, if you're doing a cadaver course, there's a good chance you won't find it, or it'll be involuted and it'll be kind of just a blob of fat. It won't look, like this nice white color like this. And so it's usually only found in children because it involutes by adulthood. And it's the primary lymphoid organ that's responsible for maturation of your immune T cells. So you remember you have two T cells and B cells. The B cells, remember B for bone marrow, they mature in the bone marrow. The T cells actually, they're produced in the bone marrow, and then they come up and they're matured in the thymus. So the pathology of the anterior mediastinum, this is a good rule of pathology, remember, is that it's one of four possibilities. So it's one of these four things, okay? So thyroid pathology, it can be one thing that's found. A thymoma, which would be a mass in the thymus here. A teratoma, which is, another type of tumor that can occur here in the anterior part of the mediastinum. These can get actually fairly large. Thymoma is also important to be aware of because it can be associated with myasthenia gravis. And then you can also have, what's really important, especially in children, is T-cell lymphoma. You can have a T-cell lymphoma in the anterior mediastinum. So, thymus pathology, abnormal proliferation of immune cells in the thymus. It can be a pathogenic process for T cell mediated acute lymphoblastic leukemia, so ALL, and this would present with a thymic mass. So you would have these children, this is commonly in children, you have this mass that grows in here. It's commonly in teenagers. T for teenagers is often where the population this can occur in. As we said, patients with myasthenia gravis, they can often have a thymoma. And what's important to note is, you can have this abnormal thymus, and sometimes if you take this out, it can actually help them improve clinically to a significant degree, because it's thought that this is producing the antibodies. Because if you remember, the pathology in myasthenia gravis is that you're producing antibodies against acetylcholine receptors, which is found, as you remember, at the neuromuscular junction, which is what gives people muscle weakness. So they're producing these antibodies that go and attack the neuromuscular junction, versus if you cut this out, then if it is in fact the source of the antibodies, then you can help them improve clinically. However, some patients, it's not the source, so you can take the tumor out and it doesn't really help them at all. So that's something to be aware of. But I guess in a board question, if someone says, oh, they had an anterior mass removed and they ended up, regaining muscle strength and function, then it can clue you into, they had a thymoma that was potentially the source. So DeGeorge syndrome, if you remember, that's 22q11 deletion, chromosome 22q11, and there's a lot of complex things, but really what we'll talk about here is just for the thymus is that they have an incomplete development of the thymus, and then a result of that, it makes them immunocompromised because these children have reduced T cells, and then as a result of that, they have a decreased humoral immune response. So that's something to be aware of for DeGeorge. They also have, many other problems, congenital heart problems and facial, craniofacial abnormalities and so on. And all right, that finishes out our discussion of the superior and anterior mediastinum. In the next lecture, we'll talk about the middle mediastinum.